Please review division guidelines prior to beginning the procedure. Patients eligible for LISA are infants less than 28 weeks gestation with evidence of RDS and oxygen requirement greater than 30% who are spontaneously breathing on CPAP for 1 hour within the first 72 hours of life, or infants greater than 28 weeks gestation spontaneously breathing on CPAP with oxygen requirement greater than 40% for 1 hour within the first 72 hours of life, as well as all gestational ages if the PaCO2 is greater than 65 on 2 CBG or ABGs. Contraindications for LISA include any infant with frequent apnea requiring intubation and mechanical ventilation, severe respiratory acidosis and/or widespread atelectasis on chest X-ray, pneumothorax requiring chest tube placement, obvious congenital facial or airway anomalies, known cardiac anomalies, or no experienced personnel being available to perform and monitor LISA. Do not attempt to use the laryngoscope unless pre-use checks as described in the user manual have been carried out successfully. Please note different probes for different size blades that are stored separately. Match the color of the dot on the blade packaging with the color of the probe. Please gather all necessary equipment: video laryngoscope, warmed Curasurf, 5 ml syringe with 14 gauge needle, BD angiocatheter, Neopuff with appropriate size mask, wall suction and suction catheter, emergency airway box, a stethoscope, sterile gloves, tape measure, Sharpie marker, and pink tape. Use the Sharpie to put the vocal cord mark at the tip of the angiocatheter and pink tape to mark the lip level using age-appropriate measurements. Suction the infant's mouth prior to the start of the procedure. Do not blindly deep suction. Continuous cardiorespiratory monitoring is necessary throughout the procedure. Place the infant's head in neutral position, wrapped in a blanket with attention to maintaining warmth. The infant should receive a loading dose of caffeine prior to the procedure. LISA may be performed with an orogastric tube present. It may be preferable to leave the OG tube in the stomach to allow aspiration of stomach contents before and after LISA. Assure that the infant is stable with baseline heart rate greater than 100 and oxygen saturation greater than 90% before starting the procedure. Nasal CPAP must be delivered throughout the procedure. Power on the video laryngoscope monitor and press the recording button. Gently insert the video laryngoscope blade in the mouth and visualize the vocal cords. Place the angiocatheter in the mouth and advance it slowly between the vocal cords to the depth of the vocal cord mark. Gently remove video laryngoscope while holding the angiocath against the side of the mouth and close the infant's mouth. Verify the angiocatheter's depth at the infant's lip to assure that the angiocatheter doesn't move during the procedure. Attach the syringe to the angiocatheter. Hold the syringe upright so that the 1 milliliter of pre-filled air rises to the top. Administer the surfactant as a slow bolus over 1 to 3 minutes to minimize LISA side effects. At the end of the surfactant delivery, flush the angiocatheter with the 1 milliliter of air remaining in the syringe. After administration of surfactant is completed, gently remove the angiocatheter. The infant should continue on non-invasive respiratory support with ongoing surveillance. Oxygen administration can be titrated during LISA to maintain oxygen saturations 88 to 95%. If the infant becomes bradycardic or hypoxic, increase FiO2, provide gentle tactile stimulation, and slow surfactant delivery. If persistent or severe bradycardia or hypoxia occurs, abort the procedure and resuscitate the infant as needed. The LISA procedure should be aborted and redirected towards endotracheal intubation and surfactant delivery if there are 2 unsuccessful catheter placement attempts by the fellow or ACP followed by 1 unsuccessful attempt by the attending neonatologist, or if there are 2 unsuccessful attempts by the attending only. Post-procedural monitoring includes continuous monitoring and NICU management per usual care for infants with RDS. If indicated, a second dose of surfactant may be delivered using LISA 12 hours after administration of the first dose. Cleaning of the equipment should be done as per NICU protocol and Peak VN manual. Equipment cleaning must be documented in the logbook in the video laryngoscope equipment box. As for all procedures, LISA should be documented in the infant's chart with a procedure note.